Hi everyone, this is Nafis, and welcome to another episode of Medical Mayhem. This episode is called Bugs in the Back, so let's get right into it. A 36-year-old man presents with severe, constant lower back pain radiating down both legs that started about 3 days ago. The pain developed suddenly, and initially was only present with walking, but now is felt at rest and wakes him up at night. As of this morning, he feels that his legs are weaker, and he's unable to walk. He hasn't had any recent trauma. Yesterday, he developed urinary incontinence with several accidents. He hasn't had any problems with his bowel function. He has been experiencing fevers, chills, and night sweats. He admits to the use of intravenous heroin. On exam, he appeared uncomfortable. He was febrile with a temperature of 38.4 degrees Celsius, tachycardic with a heart rate of 132 beats per minute, blood pressure was low at 114/76, and he was satting 97% on room air. Splints or hemorrhages were noted in both hands. There was severe focal tenderness over the lumbar spine. He was in too much pain to cooperate with a thorough spine exam. Lower extremity reflexes were reduced throughout. Strength in the lower extremities was markedly reduced at 2 out of 5 bilaterally. There was diminished sensation in the perineal region, but it was otherwise intact. Digital rectal exam revealed normal sphincter tone. Cardiac and respiratory exams were normal. Okay, so obviously this patient is unwell. The main issue here is obviously the back. But before I get to that, I want to take you to where the journey really starts. The heart. Wait, no. The arm. Recall that he said that he's an IV drug user. Normally on your skin, you have bugs that live there that aren't really causing any problems. But when you're poking yourself constantly with needles, it's only a matter of time before some of those bugs can sneak through and enter the bloodstream. The bugs in the blood, or bacteremia, leads to systemic symptoms that our patient has, like fevers, chills, and night sweats, which result from a widespread inflammatory process. So the bugs are swimming along in the bloodstream, and where does all the blood in the body eventually have to come back to? The heart, of course. So when the bacteria comes into the heart with the blood, it can land on one of the valves. The bacteria sits on the valve and grows, and grows, and grows, forming these clumps of bacteria called vegetations. Let's see what these look like on our patient's echocardiogram. The bump that you see is the vegetation, and in this case, it's on the tricuspid valve. You might know that this infection of the heart valves is what's known as infective endocarditis. The inflammation of the valves makes the blood going through them create a swooshing sound, a murmur. 85% of left-sided endocarditis is associated with a murmur. But if we go back to the physical exam, the cardiac exam was completely normal. Nothing about a murmur there. What's up with that? When blood first enters the heart, doesn't it first have to go to the right side? The first place in the heart it goes to is the right atrium, and the first valve that it hits is the floor of the right atrium, the tricuspid valve. In an IV drug user that introduces bugs into their veins, the blood carries the bugs into the right atrium, and the first surface it can latch onto is the tricuspid valve. Tricuspid valve endocarditis is mostly what you see with IV drug users, with 90% of right-sided infective endocarditis being IV drug users compared to only 20% of left-sided endocarditis. It's the left-sided endocarditis that usually presents with a murmur. Right-sided endocarditis typically doesn't. That's probably because the right side of the heart is on a much lower pressure system compared to the left, and blood moves around less forcefully, therefore creating less noise. Once the bacteria is in the heart, some of the bacteria can break off and get pumped pretty much anywhere else in the body, like the brain, joints, spleen, and, you guessed it, the spinal column. When the bacteria moves to distant sites in the body and causes another infection there, it's called a metastatic infection, and it's one of the feared complications of infective endocarditis. The bacteria make their way from the heart to the vertebral column, which has a marrow that's highly vascularized, so there's no shortage of entry points for the bacteria to seed. Once the bacteria makes a home in the backbone, which is called vertebral osteomyelitis, it causes destruction of its surroundings to the point where some of the surrounding bone dies off. The pieces of dead bone surrounding it, called sequestra, can make it harder for immune cells to get to it and fight. That allows the bugs to keep growing and growing out of control. They grow and grow and grow until they spread to the surrounding space. Recall that the vertebral column is meant to protect arguably the most important thing in your body that goes through it. It's what allows you to move and feel with your arms and legs, your spinal cord. When the infection extends to outside the vertebral bones and gets dangerously close to the spinal cord, white blood cells start rushing to the scene, and you get a ton of inflammation. All that inflammatory debris builds up and you get an accumulation of pus in the space surrounding the nerves, which is called a spinal epidural abscess. When the epidural abscess gets big enough, it compresses the spinal nerves and stops them from firing when you need them to, which is bad, bad news. To quickly recap some very basic anatomy, you can see here that we've got the spinal cord dangling down from the brain, and it's surrounded with vertebrae that protect it. The vertebrae are grouped according to their position in the vertebral column. You've got 8 cervical vertebrae at the top closest to the skull, 12 thoracic vertebrae in your mid-body, 5 lumbar vertebrae in your lower back, and 5 sacral vertebrae at the bottom. All the vertebrae have jelly-like discs between them that provide some cushioning, but that isn't shown here to keep it clean. At each vertebral level, you've got nerves branching out of the spinal cord to carry signals to your body parts. This starts in the motor command center of the brain as an upper motor neuron, which carries the first motor message into the spinal cord. When the signal needs to break off from this highway of information to get to, say, your arm to tell it to move, the upper motor neuron talks to a lower motor neuron outside of the spinal cord, which gets the message and sends it to a muscle in your arm to make it move. When it comes to what's below the belt, it's important to note that the actual spinal cord ends at the level of the second lumbar vertebra, or the L2 level. From there, the remaining upper motor neurons pass the baton to a bunch of lower motor neurons, which go down together in a bundle called the cauda equina, meaning the horse's tail, which is exactly what it looks like. The nerves from the cauda equina sprout out of the sacrum to innervate the muscles of the legs, the bladder, and your anal sphincter too. They also provide sensation to the skin near the anus, which is the perineum. If these nerves shut off, you might expect a loss of bladder and bowel control and leg muscle weakness. The cauda equina nerves go from the lower back and split down both feet. So if the nerves here become irritated, you get pain in the lower back radiating down both legs. You'd probably see reduced leg reflexes, which are the patellar and Achilles reflexes, since the nerves can't communicate properly to make the muscle groups jerk. Going back to the history and physical, we know that our guy has severe lower back pain radiating down both legs, with severe leg weakness. He also has some bad urinary incontinence. He's peeing himself left and right. He hasn't had any bowel issues, but that's not too far off if things keep going the way that they are. On the physical exam, the problem clearly seems to start at the lower back, but extends into both of his legs, because both strength and reflexes in the lower extremities are markedly reduced. He's also had a loss of sensation in the perineum, which is called saddle anesthesia. The compression of the cauda equina causing severe lower back pain radiating down both legs, with associated leg weakness, loss of bowel or bladder function, and saddle anesthesia is known as cauda equina syndrome, and it's an emergency. These are the red flags that you should be asking all patients with any kind of back pain on your clinical rotations. In this case, the cauda equina syndrome is due to a spinal epidural abscess, but it can also be caused by a herniated disc, tumor, trauma, and other things too. The spinal epidural abscess came from vertebral osteomyelitis. How do we know which vertebrae are infected? Well, the pain is in the lumbar region, so we know it's one of the lumbar vertebrae, and it's probably 2 of them. The reason why is because the segmental arteries supplying the vertebrae actually bifurcate to supply 2 adjacent vertebrae. So hematogenous vertebral osteomyelitis causes bone destruction in 2 neighboring vertebral bodies, as well as the disc sandwiched between them. Let's find out the mystery with an MRI of the spine. In this T2 MRI of the spine, where the brighter stuff indicates edema and inflammation, you can see that there's a collection of pus right here, beside these 2 vertebrae, which also look whiter than the rest of the vertebrae in the spinal column. Remember I said there are 5 lumbar vertebrae, and it starts up here as L1 and ends down here as L5. The rest is sacrum. So it's L3 and L4 that look whiter and are therefore inflamed. The disc sandwiched between L3 and L4 is also much more narrow than the rest of them, and it's much brighter too. So there's osteomyelitis and discitis of L3 and L4 with an associated spinal epidural abscess. So what do we do about it? Can we just give him antibiotics? Definitely not. We don't have time to wait for antibiotics to work. If cauda equina compression continues unchecked, it can result in permanent nerve damage that can render our patient a paraplegic. On top of that, they have to do something about the infected vertebrae. Remember I said that bacteria makes islands of dead bone called sequestra that surround it? Turns out that's a pretty good way to shield it from antibiotics that need to get there through the blood. So a spinal epidural abscess is a neurosurgical emergency. They have to cut them open and drain the abscess from the space overlying the nerves. And because of the sequestra, we can't just use antibiotics. We have to cut the infected bone out too, which is surgical debridement. So there you have it. In summary, our patient was an IV drug user and developed right-sided endocarditis as a result. He also developed vertebral osteomyelitis as a complication of the infective endocarditis. And that ultimately progressed to a spinal epidural abscess that compressed his cauda equina, that led to severe lower back pain, radiating down both legs with bilateral leg paralysis. This was a surgical emergency and required urgent decompression to avoid permanent neurological deficits. Thank you very much for watching this episode of Medical Mayhem. If you enjoyed it, please like the video, share it with your friends, and subscribe to the channel. Until next time, this is Medical Mayhem.